So, honest answer. How many people did prepare for today? Okay, good. No, because I'll talk more, right? So 2 people, not many at all. So I'm not going to go over the PowerPoint per se from beginning to end. It's long, I'm sorry. There's a lot of interventions on there. Today's focus is all about spinal cord injury, neurogenic shock, and neurogenic pain. The neurogenic pain, there's a video, it's 13 minutes, 6 slides, not difficult. It's very repetitive. When we think about pain, the concept of pain, you've got it over and over and over again. So we're focusing only on that neurogenic. What's the differences and what are some medications? Okay. Neurogenic shock is embedded within this PowerPoint. So we'll be talking about neurogenic shock today. There is a video from, is that Sarah RN? Please watch the video. It's about 20 minutes. It's an excellent video, And then do the questions at the end. You know that there's a little button, take a quiz here. Take the quiz. There's a whopping 10 questions. Take the quiz. Okay? So I'm going to do a little overview of spinal cord, and then we're going to get right into the case. As we go throughout the case, then we can dive a little deeper when we're applying it actually to a patient. So much of the slides are embedded into the case, and I can let you know which slides as we're going through. So if you want to reference that, we can. So spinal cord injury can come from many different things, right? It could be something acute, like a motor vehicle accident, that's one of the top things. Elderly patient falling, so when we think about lifespan considerations, falls for the very young, the very old. Or it could be something related to a tumor. Think about metastatic, because we had oncology segment this semester, cellular regulation. So think about the oncology process. If something metastasized and it goes to the spinal column area, we're going to have impingement on the spinal cord, end up having an injury. All depends where on that spinal cord. So I love this first picture because it really shows where the injury is and the effect. So what do you need to know? When you have an injury, if you turn it on anyway, if you have an injury at the T6 level in this green area, you're going to have injury effects all the way down. Everything below. It's a basic concept that you have to know. Have to know. Because when we say someone has a cervical injury, this thing doesn't work good. In the purple area, I can see the C3 and the C4, C5 and 6 come down on the arm. But if you're a T1, T2, that's that very top green bar, T1, T2, everything below is going to be affected.
Oh, so from T1, not T6.
I probably
said T6 first, but T1.
T1.
I'm just giving an example at different areas on this picture. Make sure that you know that the order, starting from the top, C1, 2, 3, 4, 5, 6, 7, T1, 2, 3, 4, all the way down to 12. Yes? Okay? Because somebody will say if you have a T12, they might confuse it with up here. It's not, it's down here. All right?
So if you have a cervical injury, it would be everything below the cervical injury, right?
Right, so this is a map of the dermatomes, color coded, just so you can see it better. Right, so it's going to affect your arms, your breathing, your abdominal muscles, right? All extremities. If it's cervical, yes, anything above the sacral area is going to be bowel and bladder. So guess what? Everybody's got neurogenic bowel and bladder. Right? Understand that concept? All right, let's go back. I don't want this selection. When we talk about all the concepts today, you're going to see, yes, mobility, because we have a loss of motor function. Think about what the spinal cord does. It's messages of motor and sensation, and we have reflexes as well. So mobility is the overarching concept, but we're going to have issues with bowel, bladder, right? So digestion, elimination, sensory. How about the mood and affect? Do you think a patient might be anxious if they're never going to be able to walk again? Or if they now need assistance with any kind of ADLs? So lots of family dynamic changes. Depending on where your injury is, you might be going to have a gas exchange problem or a perfusion problem. So we're bringing in all these concepts that we've been going through since the beginning of time, right? So bring all that knowledge with you as we move closer to the end of the semester. Now you're going to start seeing all these concepts thread through specific illnesses. And we see it with spinal cord injury. We're going to see it again with burns, right? Because it affects all systems. So spinal cord injuries affects all systems. All right. So let's get right into the case study. And there are two handouts. One is this spinal cord injury key points. So there's 42 slides on that PowerPoint. You can get those 42 slides, information, into this one handout right here for a study tool. All right, it is set up by systems. Again, if you want to write concepts next to each system, then you can. But it goes from head to toe. One thing that's not on here should be pain. Okay, so I would add pain on here. But the acute care, that's how our case study is going to start, and then go into rehab, and then we'll talk about a little bit about the lifelong processes. Okay. So let's put that over to the side. We're going to talk about TW. So TW is a 27-year-old who fell 30 feet from a chairlift while skiing and landed on hard packed snow. He's now in the emergency department with a suspected cervical and thoracic fracture with tetraplegia. What's tetraplegia mean? All four. Excellent. He has a cervical collar on with block pads in place. He's on a scoop stretcher. So you can see in the picture, the block pads, the cervical collar, you can still move from side to side a little bit. So the block pads are going to help immobilize better. Right? Strapped on. Scoop stretcher is just a stretcher That basically cuts in half so we can slide it underneath the patient or log roll the patient a little bit, slide one side under and then the other side. That's all a scoop stretcher is. All right, a little bit easier to move the patient. He has a past medical history of anxiety and alcohol use disorder. I'll let you look at the vital signs and the Glasgow-Coma scale. His general appearance, he's awake, he appears scared, shallow respirations, lung sounds are clear in the upper lobes, diminished in the basis. He's got an S1, S2, colors pink, skin warm and dry, pulses 2+ in all extremities. He's alert and oriented ×3, Perla. Slurred speech, no sensation of movement of extremities, and has a positive Babinski. Hypoactive bowel sounds in all quadrants, abdomen soft, non-tender, and he hasn't voided yet. Here are his labs. I'll let you take a look at those. So before we even go to the first question, why don't you take a minute and highlight and circle anything that you're concerned with on this page. Any concerns that you have. Can you picture the patient right now, what we have for a patient? So let's identify, we have multiple options here, but let's identify these 7 concerns that need follow-up. His heart rate, how's his heart rate? It's low, he's bradycardic. Why do you think he's bradycardic? Because he could be in neurogenic shock. So upon injury, patients may display neurogenic shock. We're going to talk about that. What can we do for that heart rate? Atropine.
Fluid.
Not so much fluid. For the heart rate, a pacemaker, temporary pacemaker. Okay. So that means you're going to want the patient on a monitor, right? All right, glucose.
Elevated.
It is, what is it? Let's see, 180, so it is elevated. Are we gonna circle it or not?
No.
No, not right now. Normal response. Blood pressure? It's low, it's 86/52. Okay, Ryan, now what do we wanna do?
Fluids.
We can give some fluids. What's our goal? What do we want?
Over 90.
I thought you guys said all the crap. You seem to know the answers. So you want your MAP, your mean arterial pressure, between 85 and 90, which is much higher than what we're used to, right? Because we want to provide blood, oxygen-rich blood and nutrients to that spinal cord, promote the healing. Okay? If needed, then we're going to give some vasopressors. Part of neurogenic shock, we expect it to be low upon injury. Creatinine, it's all right, it's 0.9, it's within normal limits. Motor response? Yeah, it's absent, right? So that's a problem. Urine output? That's a problem? He just came in. So it might be, you gotta watch it, so we can go either way with that. When was the last time? Was he incontinent? He just arrived. What do we expect?
30 ml per hour.
We do want 30 mLs per hour, 0.5 per kilo.
We're gonna put a Foley.
We're probably gonna end up putting a Foley in, because what's wrong with the bladder at this point?
To have a neurogenic bladder.
He's got a neurogenic bladder, because if he's got cervical thoracic injury, remember that dermatome picture? Cervical, thoracic, everything below is going to have some type of impairment potential.
So would you highlight it?
Let's see if we have 7. Quality of respirations. They're shallow. Lung sounds are diminished in the basis. So what do you think about that? ABCs, we don't like it. Right? And we're also concerned about a secondary injury. So think about the spinal cord within that spinal column in the vertebrae. Is there a lot of room there? If you have a traumatic event, a fall, right, or a motor vehicle, we're going to get immediate swelling. That happens. So secondary injury is damage to that area that is increased or potential long-standing damage, but symptoms are exacerbated because of that swelling, because of that hemorrhage in the area. So even though he may have that thoracic injury, it may appear higher because of that swelling, that inflammation that's happening there. Maybe some blood hemorrhaging in that area. So the quality of the respirations and them being shallow is very concerning because of our ABCs and questionable secondary injury. Skin temperature? Do we even have a temperature? Oh yeah, we do. 97.2. Okay. So not too bad. And his skin is warm and dry. Alcohol use disorder?
Doesn't the warm and dry skin indicate possible cooling?
Is your skin warm and dry right now?
Not really, it's kind of clammy.
Well, that's a problem. Right? What do we want to assess next?
Check his blood sugar.
Check his blood sugar and what else? And his blood pressure. Okay. He could get, are you going to shock?
Between the blood pressure and the warm, dry skin.
Right, but when we're doing a select all that apply, take each line individually, true or false.
Right, but my thing is like how from the abnormal is abnormal? Or like, I'm sorry, how from the normal, how far away from the normal it being abnormal, like 57 for the heart rate? It's 3 points below the normal.
It is 3
So,
points.
like, that's where I find the jumble. Like, when do I highlight when it's?
Is it outside of the norm?
Yeah.
It is outside the
This is
norm.
the glucose.
So is this glucose,
And I
which
just
is,
highlight that.
okay,
Like,
then you can come back and see how many, because you only get to highlight 7. Okay, so you can put a question there. You can put a question there. And then you're gonna determine from there, which is more important. Which one's urgent versus emergent, right? If you had the choice between a heart rate being bradycardic, let's focus. If you have a choice between a heart rate being bradycardic or blood sugar being high, which one are you gonna pick?
Heart rate.
What are you going to pick?
The heart rate.
The heart rate. Absolutely, the heart rate. Okay. Where are we? Alcohol use disorder.
I think he fell because he was drunk.
I mean, it's interesting, but it's not an
Okay, so if he fell because he's drunk, does it
I don't
matter?
have any ethanol levels.
We don't have an ethanol level, so we do want some more information.
And you could be sober for 20 years.
Could be sober for 20 years. Is there anything in here that was concerning related to his alcohol use? Slur of speech, excellent. Is it because of the alcohol or is it because of a neuro change? We don't know. We don't have enough information. Right? So it would be concerning. Pulse ox, let's stay focused. What about the pulse ox? He's on 4 liters. He's at 92%. So he definitely needs more oxygen, right? But his respirations are shallow, so that's a concern too. And how about the pain? He doesn't have any. Is that a concern? Yes. Yeah, it's a concern. All right, so how many did we highlight here? The heart rate, the blood pressure, the motor response, the quality of the respirations, the alcohol use disorder, the pulse ox, and the pain. What's that? Is that 8? Pain is 8, 5, 6, 7. Oh, that's 7.
So we're not concerned, Professor, about the urine yet, right?
All right. There's too many people talking at once.
And so the urine output is not concerning as he's a brand new emergency room admit, right?
How long have we had them? Minutes.
See, that's like a little like distractor, right?
Yeah. Yep. So you gotta take the context of the situation at hand. If I ask the question differently on this spinal cord injury sheet, is the Foley and the urine output going to be on here? Absolutely. But in this case scenario, immediately, I don't care if he hasn't urinated yet. I got other things that I need to focus on first. Right? Let's move on. The nurse identifies that priority concern is the client is experiencing, let's look through these, as evidenced by option 2 and 3. So take a minute and you can talk with each other now. happening with TW? What's our priority concern? neurogenic shock as evidenced by the blood pressure and the heart rate. Did it make anything different? Trickery. How is it okay, so there's some distractors that go together, and you're going to see that there is some information with autonomic dysreflexia, with neurogenic shock, spinal shock, and hyperglycemia. That's on purpose, right? So which one is the priority? What is the patient exhibiting? What's your biggest concern? Okay? What's your priority concern? Go back to the questions, and what is it asking? Your priority concern. Okay, number 3. Identify which clinical manifestation is consistent with which category. I know you guys love these. And for extra fun, I added that it may be more than one option. Because I'm here to tell you that you will mix up neurogenic shock, spinal shock, and autonomic dysreflexia. They are 3 very, very different things. So the goal at the end of the class is that you understand those 3 different complications, really. So hypotension, neurogenic, no sensation of extremities, spinal, bradycardia, neurogenic, it is autonomic as well. It is both. Bradycardia is both. It's neurogenic and autonomic dysreflexia.
Oh, I like your place.
Diaphoresis.
It's too cold.
No reflexes? Oh, I'm sorry. No, it's autonomic. Your skin is warm and dry in neurogenic shock. Warm and dry. So you're not diaphoretic. No reflexes. No, in autonomic, your reflexes are exacerbated. Spinal shock is what? Absence of all reflexes, absence of motor and sensory movement. Where autonomic dysreflexia, you cannot be in spinal shock and have autonomic dysreflexia. You can't, not at the same time. Your spinal shock has to subside or begin to subside before you can have autonomic dysreflexia. We're going to talk more about it. Hypertension.
So, I'm sorry, autonomic.
Autonomic. What was your question? No reflexes is just spinal. Distended bladder. Distended bladder is what? Autonomic. Anything else? Spinal. What's neurogenic shock? It's a distributive shock. Is your are your kidneys getting perfused? No. Kidneys aren't getting perfused, so if anything, you're going to have low urine output. You have to have a distended bladder, right? We're trying to bring up that blood pressure. We're trying to bring up that heart rate. Our skin is warm and dry. The nervous system isn't working properly. So we're hypotensive, we're bradycardic, We have venous pooling, the blood flows to our extremities, so our skin is warm and dry. Very different than other types of shock, like septic shock. Since we have venous pooling, what else do we have? Potential for thrombosis. Okay, so distended bladder comes under our spinal shock and our autonomic dysreflexia. Flaccid muscles, no motor movement. Spinal shock. It's limited to the spine, to the neurosystem. It's listed to the spinal nerves. What do the spinal nerves do? They transmit things, right? So motor movement, sensation, reflexes. So spinal shock, spinal nerves. What's the purpose of those nerves? Neurogenic shock. It's a type of distributive shock that's a problem with the neural system. That's the cause. Septic shock is a distributive shock. It's a problem with infection. All right, so neurogenic shock is very different than spinal shock. Good, seeing the difference? Headache. All right, so let's talk more about neurogenic shock. It's slide 13 on your PowerPoint. We know when a patient first gets injured, there's some kind of traumatic event or process that's occurring, and they can go into a shock. It's neurologic in order, so therefore it's neurogenic shock. There's an alteration. And what do we see? We see hypotension, bradycardia, skin is warm and dry, and we have all this venous pooling. We know that that spinal cord is very sensitive to oxygen and nutrients, and we want to promote healing, prevent further injury. So we want to get that heart rate up, we want to get that blood pressure up. We have this massive vasodilation. Our fluid balance is okay. Our capillary membrane is okay. So we don't have any fluid leaking into the tissue. We're just extremely vasodilated. So what can we do? Our goal, we want our blood pressure to be above 90 and our MAP 85 to 90. What can we do for our blood pressure? IV fluids. And if the fluids don't work, then we can give pressors. Our exemplars were norepinephrine or an inotropin. Okay? But we have enough fluid in our system, we just don't have any vasoconstriction. So our fluids might not be enough. We might need that vasoconstriction effect from the medication. What's our concern if we give all this fluid? Fluid overload. How would we know? Crackles. So lymphedema is laid, and that's right-sided. What side do I care about? The left side. So give me some symptoms of left-sided fluid overload. Shortness of breath. My respiratory rate is going to increase. What else might happen? I get crackles.
Your pulse ox.
My pulse ox would start to go down. Okay. So I can give fluids, vasopressors, that's for the blood pressure. What can I do for the heart rate? Atropine. If it stays low, I give the atropine. Are we going to keep doing this bouncy bounce thing? So a temporary pacemaker. Takes a while to set up. It's an invasive procedure. Okay, but until that occurs, or if that needs to occur, atropine is going to be my drug of choice. Now, we could put pacer pads on the patient, an external pacemaker. What about all this venous cooling?
DVT prevention.
So any kind of thrombosis prevention. So what are some examples? So heparin or Lovenox, compression stockings, the boots. Range of motion's gonna be later, because don't forget, our blood pressure is really low. So we're not gonna start doing physical therapy at this point. We're trying to stabilize our patient. So those Venodyne boots, compression stockings, promoting that blood flow back. With all this venous cooling, our skin is warm and dry, but what's our core temperature? We're hypothermic.
Warm blanket.
So we might warm the fluids, we might put a warm blanket on the patient. They might need what's called a bear hugger, or it's like a blanket that flows hot air through it. Something like that, and a nice cold.
That would be good for you.
All right. How about spinal shock? Slide 18. What can we do for spinal shock? Spinal shock is very different. We see for manifestations, absence of reflexes, no motor movement, no sensation. You get nothing. They're like a complete injury. Do you understand what that means when I say a complete injury? That means no messages are getting below that level of injury. None. You get nothing.
GIG support.
What's that?
GIG support.
Okay, so definitely a Foley, NG tube to suction. So depending on the level of injury, they need to be intubated. Cervical injuries, 9 times out of 10. If you're a high thoracic injury and you get some edema, what's going to happen? You have secondary injury, not monitoring the patient, it can present as a higher level injury. That's secondary injury. We're still going to focus on the spinal shock for right now. Are there any medications? Your book talks about one. I didn't put it in the PowerPoint because there's a lot of controversial. No? What decreases inflammation? Corticosteroids. So for a very, very long time, we used to give high-dose steroids. High-dose steroids. What happens when you give steroids?
Blood sugar.
What are the side effects?
Blood sugar goes up.
Risk for infection. Blood sugar goes up. So now we're starting to think about, what's the risk versus benefit? So after all these studies, they say if you're going to do steroids, you got to do it right away. And what's the risk and benefit for the patient? Because the studies in the end are not really that effective. The outcomes seem to be the same. All right. So you may or may not see steroids being administered. What's another intervention? But I don't think of it as to me it's an intervention. You may think of it more as an assessment.
Again?
Okay, I like the neuro better, because why? What do you need to monitor? The what? I still didn't hear
It's
you.
like Glasgow?
They're getting perfusion to the brain.
So we're not talking about brain function, we're talking about spinal shock. One of your interventions is to monitor the patient and to assess Well, what am I assessing for?
Their sensation.
Their sensation, don't make it too hard, and their motor movement. And what else? There's one more. The reflexes, because that's what's happening with spinal shock. We have no motor, no sensation, no reflexes. Let's look at him, TW. What does he have? No motor under the neuro, no motor or sensation of extremities. He's alert and oriented times 3. It's not really those. Okay. We're going to focus on the spinal cord. Per slurred speech, again, we already said, is that a neuro head trauma issue, brain injury, or is it alcohol related? So we would need more information with that. And no sensation or movement of extremities, positive Babinski. What does that tell me?
Not good.
Yeah.
Right? Something's wrong.
That shouldn't be there. It shouldn't.
He has reflexes because of the positive Babinski. We know we don't want that, but does he have a reflex? Is he in spinal shock? No. We're only talking right now, this minute, about spinal shock. Do any of us want positive Babinski? No, we don't. But let's put this away for a moment and think about what is spinal shock and what are our interventions. How do we recognize a patient's in spinal shock? I'll say it again, there's no movement, no sensory, there's no reflexes. He's got a positive Babinski. He's not in spinal shock. It's very easy to determine when someone's in spinal shock. They mimic a complete cord injury. They've got nothing. Okay? Let's move on to are we good between neurogenic shock and spinal shock? Yes? Not much that we do for spinal shock, right? We continue to monitor it basically for a return of those reflexes, a spasm, a motor movement, sensation. Go ahead, you have a question? That's the big difference. Neurogenic shock is systemic. You have hemodynamic instability from a neurological event. Okay? Yes? Questions?
I have one.
Sure.
Can you have neurogenic shock at the same time as spinal shock?
Absolutely. If he had no Babinski, he has both. He has both. You can have these at the same time. And many times you do. Many times you do.
Now, if you have a complete spinal injury at a certain level, you're not going to have any motor sensation below that anyway, right? So how do you differentiate between spinal shock and a complete
Because you
injury?
still have reflexes.
You will still have reflex.
Abnormal. Yep, you'll have spasms.
Okay.
Higher injuries above T12, you have an upper motor neuron impairment, you're going to be spastic. You're going to have a lot of spasms.
Okay.
Lower motor neuron, that's below the T12 area, lumbar sacral, that's going to be more flaccid because it's the lower motor neuron. You can YouTube a video on that. I'm not going to get into the top though, because I want you to know the difference between spinal shock and neuro shock. Okay? But if you do a quick YouTube search on upper motor and lower motor neurons, you'll find a short video on that. Okay? So, spinal shock happens usually within that, upon injury, shortly thereafter, at the beginning. So when we look at that acute column, this acute column, shock should be written in here. Neurogenic shock should be written in the acute column, right? Because we're in that acute phase right now. Okay, so we begin to plan our care for the patient. For each order, specify whether the order is appropriate or not appropriate. IV fluids? Yes. Why? Because of his blood pressure and his MAP, he's in neurogenic shock. Strychnine? Yes. Insert indwelling catheter? Yes. Oxygen via venti mask?
No.
No. Who's got time for that, right? Do we need a specific amount at this moment in time? No. What's our issue? We need to get it on because the stats are low, right? He's 92 on 4 liters. So what would you recommend?
Non-breather.
A non-rebreather. Go right to the end. You can always titrate back. Do not discriminate. Always oxygenate. Always, always, always. What else would we anticipate for this patient? Probable intubation, because his respirations are shallow. So what's the effort of that breathing? Is it shallow? Is it deep? Is the chest regularly moving? That's not effective. You have all the oxygen in the world, that's not gonna matter if you're not taking a deep breath. Neurological assessment every hour? Absolutely, it's probably gonna be more frequently actually, because we want to monitor those signs and symptoms. Respiratory assessment every 2 hours? Way more frequently, right? Every 2 hours. It has to be at least every hour, okay? The neurological assessment absolutely is going to be every hour. Every hour, and our respiratory assessment every hour.
So when you put that every hour.
Indicated, not indicated. Indicated, not indicated. Meaning you need it more frequently. Just the time frame, just because of the time frame. So providers should not be putting an order every 2 hours for a respiratory assessment on someone who has a cervical thoracic injury, right? Isn't he a T1 injury on his CAT scan? That's not reasonable. A warming blanket? Yes. Compression boots? Yes, because of that neurogenic shock from venous cooling. Cardiac monitor? Yes, neurogenic shock, atropine phaser. Maintain cervical collar? Yes.
So you would, the reason why you're gonna put a warning blanket is because he's not like that, this will be better.
Right. So your skin is warm and dry, but your core is going to be cold. So what's your priorities at this time? ABCs. We want a patent airway. We want respiratory effort. If we don't have it, our patient has to be on a ventilator, right? So those assessments and diagnostics, yes? We want to prevent further core damage, so we have to immobilize the patient. What are some ways that the patient, God bless you, is going to be immobilized? Yes, the cervical collar. So log roll. So that doesn't immobilize the patient. You're talking about the turning bed?
The block stuff, I forgot what they're called, but
Okay, so the cervical collar blocks, can we leave the patient like that? Not for long, right? Because they're gonna get some skin breakdown on the pressure points on that stretcher. So we definitely want to send them off to CAT scan to find out where the injury is. And when they come back, yes, they need a cervical collar, we need to maintain that. But what's gonna be used long-term?
Probably a halo.
So maybe a halo, if we don't have any bony fragments in there.
But if they don't find anything in the CAT scan, they're not gonna move it.
Correct. They may use it to stabilize that spine.
Doesn't that only stabilize your
Cervical, yes, it does. So it depends what you're gonna see. What are some other options? We don't want to use sedation because we want to see what their neurological status is. So we have to be careful with sedation. Okay, so Gardner-Wells tongs. There's a picture in the PowerPoint.
Surgical stabilization.
Maybe surgical stabilization. So there's many options. All right, Gardner-Wells tongs is a way that's going to help stretch that out. Maybe the discs are gonna move back into place, keeps the patients on bed rest. Gardner-Wells tongs kind of reminds me of buck traction. However, this is different when you're talking about screws into the head. Let's see, there's a picture in here somewhere. There it is. Right here. All right, where weights are hanging over the bed. You don't want to hit these weights, right? The bed's going to be moved away from the wall. Kind of same concept as buck traction, where it maintains, exerts some pressure, and it maintains alignment. Temporary. The patient's either going to need some kind of halo or a surgical intervention. Again, up to the provider, depending on what those results of the x-rays are. Okay? But until the patient has something long-term for stabilization, your focus is to mobilize that patient. Because we want to prevent any further damage. We're focused on that neurogenic shock, right? Maintaining the blood pressure and the MAP and our heart rate. He fell 30 feet. Think something else might be going on? Probably. Unlikely that you get just a spinal cord injury. That's it. There's probably a broken bone. There might be a head injury. Right? So now you're coming in with all those other neurological. What's the pupils? What's the speech? What's the Glasgow? Well, that's for stroke.
Oh, yeah, you're right.
That's stroke. Okay.
Swimming there.
How do we know if someone has a fracture? It might be visible. There might be bruising or bleeding, swelling. Right, so we're looking at the whole patient. All the clothes are coming off. We're visually inspecting. What about those labs? They might have a bleed, so we're looking at the H&H. Well, when we put in that NG tube, what was the output? When you put the Foley in, what was the output? Is any of it bloody? Right, so constantly assessing, and we do that normally. With any tube or drain, what's the amount, the color, and depending on what it is, the odor. Right? That's the same concept for any kind of tube or drain. What about the family and the patient? So Okay, so maybe notification to the family that there's been an accident when you come to the hospital. You don't want to give a lot of information over the phone, right? What about when they come there?
You want to prepare them for what they're going to see.
Prepare them for what they're gonna see, provide support to them. What about the patient? Because he is alert and oriented.
Ask them who you want to call.
Ask him who he wants to call. Okay? How do you think the patient might be feeling?
Pretty scared.
Oh, very scared. Very scared, very anxious. Okay. Do we want to monitor for any signs and symptoms of those complications? That's slide 25. We come back to our case. So a lot of priorities. Number 7, which assessment would you complete first?
Respiratory.
Any other options? How do we prioritize? ABCs, emergent, urgent, Maslow's. What's going to kill them? Right? Okay, so the answer is B, ABCs. Okay, although his injury is at a level where independent respiratory function is expected, he starts having low O2 sats more and inadequate respiratory effort. He's placed on the ventilator. The provider says it's because of secondary injury. I guess we already answered this question. What is secondary injury? How will you monitor? So we know what secondary injury is, right? It's all that edema, hypoxia to that specific area in the spinal cord where the damage has happened. Could be hemorrhage, could be just lack of perfusion there. And it can cause a higher level presentation. So we don't know really where TW's injury level is. Things need to calm down first. It's almost like, you know, I don't need to be like this, but think about when you injure yourself, sprain an ankle or something, right? You can't move it, you can't do anything at first, you can't even walk on it. And then over time, it gets better. Same concept, just on a much higher level, right? So how will you monitor? Because we know what it is. How do you monitor for secondary injury? Motor and sensation, be a little bit more specific.
Well, I mean, if they completely lose all reflexes.
So if they completely lose reflexes, that's what?
Spinal shock.
Spinal shock. We're talking about secondary injury.
I thought spinal shock was.
Spinal shock is not secondary injury. What's secondary injury? Because of the first injury.
So he fractures.
So you can have more damage.
In the C's and lower.
Exactly. So if you have a fracture at T1, that's where your injury is. You have a secondary injury, it could be all that swelling, hypoxia there. Now he presents as a C5 injury or C4 injury.
Oh, I see.
So yes, motor and sensation, but what about that motor and sensation? It's gotten worse. It's gotten worse. And when you think cervical, what's the first thing that you think of? Respiratory, absolutely, always respiratory function. So monitoring that respiratory assessment and the motor and sensation to see, has it changed? Has it gotten worse? Now, if it completely disappears, well, then I know we're in spinal shock. Okay? Go ahead, question.
So a secondary injury, that's only as it's related to the spinal cord? Not
Yes.
like atelectasis, something like that, as a secondary injury, that would just be separate? It's just really as it relates to swelling in the spinal cord?
Correct.
So
Okay.
atelectasis would it be a secondary injury for somebody that had a cervical injury?
I guess I don't view it as atelectasis. I view it as, where's my injury? For this patient, it's a T1. He should be able to breathe pretty well. What's gonna affect him is those intercostal muscles, right? Your thoracic area, T1 through 5, is really all those intercostal muscles. So if you have some difficulty with your intercostal muscles, you can still take that deep breath, right? You still should be able to breathe okay. But if I have secondary injury in that spinal column, here's my T1, and now I'm up to here because there's so much edema, now I can't even take a deep breath. I can't breathe. Respirations are shallow. My O2 sats are going down. Will they probably have atelectasis? Yeah, because I'm not breathing. But I don't want to think atelectasis is secondary injury. Thinking of where it is. Does that make sense? So monitoring that respiratory assessment, is it changing? Is the patient presenting as a higher level injury? What's their motor and sensation? Is that changing at a different level? Where before they could feel their hands or maybe squeeze their hands and now they can't. Okay? How are we going to respond to the family asking questions? Is he going to be okay? Is he going to be able to walk again? Because you know they're going to ask you that. Okay, so where's the provider? Because what's the role of you and the role of the provider?
Too early to tell.
It is too early to tell. Because why? We have a lot of swelling going on, and what's your focus? The what? Stabilizing the patient. So what are you going to say to the patient and to the family? So we can get the provider to talk. The provider should always be delivering the prognosis and the information. We reinforce that. And then how do we support the patient? Acknowledge your fear. And you're scared right now, your blood pressure's low. We're going to focus on getting your blood pressure up. Your heart rate's low, your oxygen's low. Right now our focus is that. That's what we're focusing on. I'll have the doctor come in and talk to you about what's going on. Do you need to do more testing? We don't know what the long-term effects are going to be yet. We have no idea. Right? It is too early to tell. But our priority right now is your blood pressure's low. So we're going to take care of you. You're in a place, I'm a nurse that's going to take care of you. I'm focusing on your blood pressure, your oxygenation, keeping you safe, preventing further injury. Okay? So redirecting. The case continues. He goes from the ED to the ICU, surgical ICU. He's taken a surgery 24 hours after the accident, so there's that stabilization, right? And after that, he spends another couple of days in the surgical or neuro ICU, and then 5 days on the neuro unit. And he gets weaned off the ventilator. So just to kind of wrap up and summarize, number 10 and 11 is all about that acute care column on our sheet, things that we didn't talk about yet. Right? So what other things are going to occur during that hospitalization in the acute care setting? Well, neuro guys, we did what? What do we focus on? Our neurogenic shock, right? Our ABCs, maintaining oxygenation, monitoring the patient, monitoring the motor and sensation and reflexes. We know in the patients in spinal shock, they don't have any of that. But we want to monitor to see, does he start to get something back? Because if he does, that's a wonderful thing, right? Means he's got some kind of nerve messages going through. We want that. That's wonderful news. We know then that spinal shock is subsiding, but it also is going to place the patient at autonomic dystoplexia. We'll talk about that after a break. What about respiratory-wise? Same thing, right? We're monitoring their effort, their O2 sats, ventilation. Are they on a ventilator? Because when they're on a ventilator, what does that mean to you as the nurse? So we're ventilating, okay.
The body's getting oxygenated properly,
Okay,
like effectively.
okay. Yeah, what do you, when you're caring for someone on a ventilator,
Aspiration,
okay, the bundle. What's in the bundle? Oh my goodness. Yes, and what's in the bundle? PCI,
Sedation vacation.
mouth care, sedation vacation, suction as needed. We don't just arbitrarily suction people. So Ryan wants to be suction if he's ever on a ventilator. He'll change his mind after, but okay, let's not do suction. Is suctioning pleasant? Suctioning's not pleasant. Has the bed slightly elevated, right? 30 degrees, 1 mouth. Yeah, we already talked about cleansing the mouth, right? CPIs. All right, so don't forget about that bundle, because that's what nurses do, right? Cardiovascular, that's that neurogenic shock. Our fluids, our vasopressors, maintaining our blood, our heart rate, our thermal regulation. These are all for people above T6. We talk about must-know levels. Make sure we look at that before we end today. How about GI? So right away, you're going to have that ileus. Right, because who cares about the GI system? The body doesn't care about that. So you're going to have hypomotility. So NG2. Go ahead.
What are we rating here? Are we rating?
You can write whatever you want to write. So that way there, again, it's a study tool. These are all the things that, for me, if I had to take this 42 slide PowerPoint, and how am I going to study it? And how am I not going to mix up what happens in the acute care setting versus the rehab setting, which is very different, and lifelong considerations, right? We want to kind of compare and contrast that. Whether you want it in this kind of paper or some other way, then that's great, right? Now, when I say neurogenic shock, do you know what that means? Because if you do, maybe you're just writing down neurogenic shock. Maybe next to it, you need to write blood pressure greater than 90, heart rate greater than 60, MAP 85 to 90. All that's what I mean by saying you write what you want, because you might need a lot more details in some areas versus other. Okay? So the GI, we talked about hypomotility for anybody in injury T5 and above. So T4, T3, T1, cervicals. Anybody T5 and above. NG2 to suction. Once we get return of those vowel sounds, well, now we need to start feeding or eating. Eating is always best. Keeps that GI tract in place. If we've got some kind of facial fracture, some kind of multiple trauma, maybe they can't eat. Well, then we could use tubes, enteral feedings. right? But much better than TPN through a CVAD, right? Keep that GI tract moving. Must know bowel movements. When the patient had their last bowel movement. Because depending on their sensation, are they gonna A, be able to move their bowels? Are they gonna need assistance? And if you're impacted, what's gonna happen? You have bowel obstruction. It can perk. Oh my gosh, now the patient has stool in their peritoneal cavity, now they're gonna end up septic. So we don't want a bowel perk. What else? They can vomit, nausea, vomiting. We can't keep eating and eating and nothing's coming out. Right? So high calorie, we want to feed that spinal cord, promote healing. The bladder, we know initially it's a tonic. We want that Foley catheter in order to what? Maintain that urine output. We expect it to be low right away because we have all this venous pooling. Our cardiac output is down from the neurogenic shock, which is why we're giving the fluids. We want to get some blood to the kidneys to get perfused, to be excreted. So monitoring the patient for that. Skin. Can the patient move?
No.
Probably not. So what does that mean to you as the nurse?
Pressure injury.
Skin assessments. Turn in position. Check those bony promises. Keep the skin clean and dry. This sounds basic, right? Keeps coming back, coming back. About mobility, oh, and then whatever we're using for, well, I guess that goes under mobility. What do we do for mobility? So we could start range of motion as soon as possible. Helps with that orthostatic hypotension. Even just turning the patient, elevating the head of the bed. They get so sensitive to it. Gonna promote that rehab phase, the sooner we can keep moving them. When a patient's really unstable, you cannot move them at all. Not at all. Their heart rate drops and their blood pressure drops. So much so, you don't move them. Which is when we need these fluids and these pressors, stabilize the patient. Meaning the blood pressure's up, the heart rate's up, now I can reposition. Okay?
So if they have that, then you have time to care the medicine.
So then,
But if they have that situation, you have the time to care the meds. Or you just.
so when we're talking about vasopressors, we're talking about a continuous infusion and it's titrated according to the patient's blood pressure. Okay? So when you first start it, you're not moving the patient. Okay? And when you reposition the patient, if the blood pressure drops or if the heart rate drops, you're not going to turn them as much. Maybe you just put a little pillow under their side and not do the complete turn. All right? So adjusting just a little bit until they're stable. If you don't have a blood pressure and a heart rate and oxygenation, you're not living. Do we care about turning at that point? No, it's not the priority. So we want to get our hemodynamics in a reasonable manner. Now, his are reasonable, right? I'm talking lower. That's why you might see patients that have had major traumas have all these wounds because they were so unstable that they couldn't move the patient. And you're not having that blood flow to the extremities. It's shunted to where? Heart, lungs, brain. So mobility, some kind of stabilization. It could be as simple as a cervical collar. It could be those tongs, it could be the halo vest, maybe they went to surgery and had fragments and pieces removed and rods placed. So it's dependent on what are they using for stabilization of that spine, of the vertebrae, to protect the cord. Early surgical intervention is better than later. So we want to stabilize our patient, so hopefully within that first day or so, they can go to surgery, because those are going to be your best outcomes. Psychosocial, depression, anxiety, coping, right? Pain. Is the patient having pain? Where's the pain? What's the pain feel like? Because you might use different medications based on that. Diagnostics, well, EKG, cardiac monitor, CAT scans, x-rays, right? CBC, we're checking for bleeding, or chemistry. We're worried about kidney perfusion, so kidney functions, BUN, creatinine. Probably my cursor is probably covering over Teams. Couple complications, we said DVTs or PEs. How do you know if someone has a DVT? Unilateral edema, or redness, or warmth.
Ultrasound.
They may do an ultrasound, but you've got to recognize that, right? What about a PE? Shortness of breath. Can't really see shortness of breath if they're on a vent or the patient has some difficulty.
Their pulse ox will
Their pulse ox would go down. Our diagnostic would be the D-dimer. They might have chest pain. Again, depending on the level of injury, what symptoms can the patient express to you versus what are you going to say? Right? So maybe you see an increase in the heart rate because it's trying to compensate. Maybe you see an increase in the respiratory rate, a decrease in the O2 sat, but they're not feeling the chest pain. Who knows? D-dimer, nuclear scan, right, to see if there's PE. There's interventions that we can do to prevent thrombosis. We already talked about what? Anticoagulants.
The compression.
Compression boots. Now we're doing range of motion. Once our patient's stable, physical therapy will be on consult. We move the legs, arms. Okay, so there's a lot going on with this patient, yes? During their acute care. How do you promote that respiratory function, that oxygenation? Yes, the vent, we already talked about that. Well, when they're off the vent. So incentive spirometer, head of the bed elevated, cough and deep breathe. If they have a weak cough, who's at Gaylord? I know more than one person's at Gaylord here. Have you seen anything to help people cough? The assisted cough machine. Okay? So there's a machine, or you could do it manually, where you're pushing in. Okay? To help push up that diaphragm, helps a more forceful cough. There's a machine as well, it could be a mask or just a piece in their mouth, where it's going to push a lot of air in, and then it's going to suck out to help push in, exhibit a cough. There's also the vest that they put on people, right? That does the vibrating vest, like that, right? If not, what do you do? When you turn the patient and you're rubbing their back, are you starting at the bottom, working your way up? I visualize as those secretions are moving up, great, gonna get them out. Prevent that atelectasis. Percussion, chest physiotherapy. Respiratory therapy usually does it. Is it okay that you do it when you're rubbing their back? Is it okay that the patient's coughing? Yes, we want them to cough. We want a good cough. We want good air movement. Yes? All right, great. We've been going for a while. So that's those two questions, this whole side. There's a lot in that acute care. All right, any opportunity to talk. Let's all talk when it's time and ask questions when it's time, but let's move on, because TW is done with his acute stay at the hospital, and now he's medically stable, and he's ready for transfer to rehab. And your focus is to get this patient to rehab as soon as possible. Right? Best outcomes. Move forward. Plus, are we going to hold up a bed in the acute care facility if you don't meet criteria? No, there's somebody waiting in the ED to get that bed. Right? So they need to be discharged as soon as possible, once medically stable. So TW is medically stable. It's been how long? Like a week? 5, 6, 7. He's been there a little over a week. And he's going to rehab. He's ready for transfer. He has some movement in his upper and sensation in his upper extremities, and continues to have paralysis in his lower extremities. Right, so that spinal shock is subsiding. That's what that tells us. But shortly after the transfer, TW turns on the call light and he asks for medications for a headache. As you walk into the room, you see his face is flushed and he's sweating. What do you think? Autonomic dysreflexia. Okay. What further assessment do you need? Vitals. What do you expect?
Increased blood pressure.
Really high blood pressure. Like 40 millimeters of mercury above their baseline. Okay. What else do you expect? Bradycardia or lower heart rate. No. That's spinal shock. Stay away from that.
Diaphoresis.
Diaphoresis above that level. They may be anxious. They may have goosebumps. It's some kind of exacerbated reflex. So something's going haywire down here, some kind of stimulus of that sympathetic nervous system. And the parasympathetic up here is trying to compensate, but can't do it. The carotid sinus says, hey, I can help. I'll lower that heart rate. Like, yeah, so. Right? Meanwhile, our blood pressure keeps going up. You know, we don't want that. So we expect the blood pressure to be elevated for the patient. We expect the heart rate to be lower. They may be flushed, diaphoretic, anxious, vision changes, goosebumps, nasal congestion. Once a patient has it once, they will recognize it every time after that. This is something that occurs after spinal shock. I'm not saying that spinal shock goes away and then you have this. You can't have them together. It's a complication in the sense that there's a stimulus and now we have this hyper response in the nervous system. What's it typically related to?
Yeah,
The parasympathetic can't override the sympathetic. So the sympathetic nervous system is going haywire, right? And the parasympathetic can't compensate for it. Well, what's the stimulus? So I heard GI, GQ.
Bladder could be impacted.
some kind of stimulus. So what are your interventions? Figure out what the stimulus is, but before we even do that, we're gonna sit them up. Because what happens when you sit someone up? Hopefully their blood pressure goes down a little. We're not gonna bother checking it. We're just gonna sit the patient up. Even put their legs down if you can, because we want to promote that venous cooling right now. This is when we really want it. Right? And now we're gonna look for that stimulus. Majority of the time, 80–85% of the time, is the bladder. Always go to the bladder.
Meaning that it's full,
Meaning that it's thick.
so that stimulus is like a message that can't get released, right? So it's still right within that.
So it's continuous, right? Blood pressure is going up and up and up. So if the bladder's full, what are you gonna do?
Empty it,
Straight cath. If you've got a Foley indwelling cath,
Make sure it's not got any clots or
make sure it's
kinks
not
or.
clogged, it's not kinked. Sometimes it's as simple as adjusting the tubing. And it's immediate. Comes on fast, goes away fast. Minutes. If we can't find the stimulus, we've capped the patient, we've checked their rectum, there's no stool there. As we're doing this, right, the patient's sitting up. You can have someone sitting up. A little bit more difficult for a female, but at least raise the head of the bed as much as you can. Right? Anytime you can drop a leg off to the side of the bed, do that. Loosen clothes, shoes off. Once you relieve the stimulus, the patient usually starts to feel better. If it doesn't, then what? Then we're gonna need medications. What kind of medication?
something to lower the blood pressure.
Yeah. So a vasodilator. Maybe a nitroglycerin, nifedipine. Patients should carry a card, with a wallet on them, wear a bracelet. Because if you've had it once, you have the potential to have it again at some point, lifelong. It typically happens that first time, within that first year, without a doubt, but it can come back. It is scary. And the patient, once they feel it once, then they're able to direct their care, right? If it's not treated, what happens? Absolutely, hypertensive crisis, stroke, maybe MI, death, seizure, all bad things. Okay. Number 16, questions on autonomic dysreflexia. So autonomic dysreflexia should come in this rehab column. You might want to even put it in the acute care column, because depending on how long the patient's there, once their spinal shock subsides, they have the potential to have autonomic dysreflexia. Once the spinal shock subsides, they have the potential to have autonomic dysreflexia if you are T6 or higher. So T6, T5, T4, 3, 2, 1, any cervicals. Okay? So TW, we're in rehab, needs teaching for his skin. What will that include? This is slide 34. Keep the skin warm and dry, or clean and dry. What do we do for skincare? Moisturize. What else do we do? Turning and positioning. Bless you. So when you're in bed every 2 hours, when you're sitting in a chair, it needs to be more frequently, right? Are you constantly shifting your weight a little bit? So paraplegics can shift their weight independently and do wheelchair lifts. So they sit in the chair, whether they lean to one side, lean to the other side, every 15 minutes or so, or even lift up, right? Just moving a little bit makes a big difference. Okay? For a quad, they're going to need assistance with that.
Special mattress.
So I saw somebody said with the head back a little bit. Their wheelchairs are much more sophisticated versus the ones that we use to transport patients, right? They're fitted for the patient, have every bell and whistle in the sense of, kind of lean back forward. There's a specialty cushion on that wheelchair. Now, they might already have wounds from when they were unstable, so we would need to do any kind of wound care.
They have special mattresses too.
We have special mattresses and beds that constantly, rotator beds that constantly turn a patient in the acute care, not so much in rehab. But our whole purpose of rehab is what? To promote independence and for this patient to be independent and self-care. So if I can't care for myself physically because of my mobility or physical limitations, I need to be able to direct care to my caregiver. So what does that patient need to be able to do or say to somebody else?
Communicate and delegate.
Communicate and delegate, absolutely. So while we're looking at the skin, we need to teach the patient, do they have the physical means? Do they have enough arm movement where they can see their skin with a mirror, right? To look at their bony promises? Are they able to see it with a mirror maybe on a reach bar or on a stick or a wand, right? So they can look at their toes after their shoes are off. All those skin inspections. Or are they going to say, I need you to look at?
I've had patients tell me to take my cell phone and take a picture of my wound. I always think
Excellent. Take my cell phone and take a picture of this wound so I can look at it. Because guess what's going to be the demise of the patient? An infection. Whether it's respiratory, or whether it's skin, or whether it's bladder. One of those three ways, unfortunately. So a lot of self-care teaching. We're focusing on the skin right now. So using a mirror, good hydration, diet, nutrition. It's important to eat healthy, right? Be mindful of the pressure points. Be mindful of what you're wearing as far as shoes, anything that's tight, belts, binders, braces, the wheelchair. If your knee is rubbing up against the edge of the wheelchair, the outer aspect, right? Because they may not feel it. Is anybody even looking there? And any old wounds that have healed, it's scar tissue. There's not a lot of blood flow there. Easy to open right back up. So monitoring that. Moisturizers. Maintaining hydration. Okay? Number 17, a bladder program is implemented. We're in the rehab. We know that in acute care we had a Foley catheter. Although I'm starting to see a shift now where they're getting away from Foleys and starting to do straight caths. Less risk of infection. So I'm sure in your time frame bedside, you're going to see that shift completely change and maybe Foleys will go away. But we're not there yet. So in rehab, a bladder program is implemented. What type of program is expected and what outcomes, how do you evaluate to determine whether it's been effective? So what do we anticipate for this patient? So intermittent cathing, how long? 4 to 6 hours. How do you know if you go 4 hours or 6 hours? How much did you have? How much did you take out? What was your output? What's our goal? How much? So around 400 for our output. We start getting output of 600 when we do a straight cath. We gotta go more frequently, that's too much. Too much bladder distension. That's like me telling you, hey, you can't go to the bathroom. Gotta wait, gotta wait, gotta wait. Well, the patient can't feel it. Or they might have some spastic and now be incontinent. You don't want that. We want urine staying in the bladder, it's supposed to be sterile, but anything stasis, risk for infection, right? We don't limit their food intake. Again, if they have comorbidities, that's different. So we're looking at the amount. What else are we evaluating?
Color,
So monitor infection. How are you going to monitor for infection?
clarity,
Do they have a temperature? What's the color of the urine? The color tells me a couple of different things.
dehydration,
Right, hydration status, okay. Whether it's cloudy, the clarity of it, and is there an odor? We have medications that we may administer. Does anybody over a T12 is going to have probably a spastic bladder? When they get to rehab, they're going to do all kinds of urological studies to determine what plan is for this patient. But if the patient has the psychomotor ability to straight act themselves, and our goal in rehab is what? Independence, self-care, then we're going to need to teach the patient how to straight act. Is it slow? Oh, it's so slow. So slow. But would you rather cath yourself versus somebody else cath you?
If I could.
If you could. Gives you a lot more freedom and independence. You're not relying on somebody else. You know, we're going to suction in, we're going to make him cath himself. That's what we're going to do. Look out for Ryan.
One in the top, one in the bottom.
Okay. So when we cath, we're using sterile technique. When the patient caths, it's what kind of clean technique. So they're going to reuse those catheters. They're going to wash them out and reuse them. Okay. And what's your ultimate goal? Yes, you don't want them to get infections, but what other complications do you not want them to have? Dysreflexia, and we know that the main concern or cause from that is a distended bladder.
I have a question.
Sure.
There's dysreflexia follows other things as well, not just shock.
Okay, clarify.
Well, we're talking about autoimmune dysreflexia after spinal shock, but does it happen from other reasons?
So it's not happening because of spinal shock is gone. It's a complication from or an event that happens from a stimulus. So a distended bladder causes activation of that sympathetic nervous system. So our blood pressure gets high, right? The parasympathetic, and it's blocked from wherever our level of injury is. And what happens is the parasympathetic says, okay, let's settle down, but it can't get the messages through appropriately. So it's from from a stimulus. It's not, it only can happen if the patient's not in spinal shock. Can't happen then.
It's just like a neurological event, right? Like it's from a problem to a neuro problem.
Right, spinal cord injury is primarily is what you're seeing in When I think spinal, or when I think autonomic dysreflexia, I think spinal cord injury. When I think spinal cord injury, I immediately think autonomic dysreflexia. Like must know, like when you leave here today, you should know spinal cord injury, oh, autonomic dysreflexia. Because that's, again, once that spinal shock subsides, and that can subside pretty quickly. It could be days, it could be long, but it could be days. So that person has it potentially from during their acute care stays, lifelong. So no matter where you are working, if you have a patient who has a spinal cord injury, this could be something that they have.
I remember I had a lot of patients, like, they can tell they've had it for so long, that they can tell their body started.
They know right away. Hey, I need to be capped.
Yes.
They're directing their care. Not necessarily. No, it tends to happen within those first couple of months, first year. It tends to happen at that time, usually within that rehab phase, a lot of times. And in the acute care rehab. Because you're in rehab for a couple of months, 3 months. Depends, sometimes it's a month. Again, how high level are you? Are we making progress? You can ask the patient, don't forget, the patient, again, depends on their comorbidities. Maybe somebody who has had a TBI and has residual, that's different. But if you have a spinal cord injured patient, it doesn't necessarily mean that they've had a head injury as well. Or maybe that's resolved, right? And they're able to, their cognition is okay, it's not that impaired. Maybe they have a card in their wallet, if that's the case, so that way the healthcare arena would know that. But otherwise, they're directing their care. When they're in the rehab, they need to learn about this. They need to understand it. They need to direct the care. And what Nicole said is a perfect example. The patient started feeling it and said, hey, I need to be capped. And guess what? Hey, you're going to do it right away. You're not going to wait and say, yeah. No, that person is going to trump somebody else. Okay? Because it's an emergency for them. All right, now is bowel tech training. So what are we going to teach? What do we want to know? What do you want to know?
If they're able
Your
to.
last bowel movement. Do you go every day? Every other day? Every morning.
What their pattern is.
Okay. So I want to know what your normal routine is. Right? Because not everybody goes every day. And we don't need to share your bowel habits. But it is important to know what your normal routine is. Okay? And I'm thinking that if you had a spinal cord injury, you do not want to be incontinent. Because if you were incontinent with urine, I could probably put something over, no, it's not a great thing, right? But if I could put something over my lap, you probably won't see that I was incontinent of urine. But if I'm incontinent of stool, that's a whole nother level, right? So it can be very embarrassing for them. Very important to have an effective bowel regime. Otherwise, they're afraid to go anywhere. Are you not going to be anxious and probably depressed, have difficulty coping with this new injury? So now, your bowel regime is very important for that. Because you don't need that to add another layer on of anxiety. Oh, am I being right? I'm not going on. Right? Social isolation. Nervous about it. So how do we promote that? What was your routine before? How were your bowel habits? Right? Well, hopefully we didn't take stool softeners before this, but you're gonna be on them now, because guess what? We walk and move around. They're not. So that mobility, any kind of range of motion is gonna help. Physical therapy. Think about what you're eating. When do people normally move their bowels? When something comes in, something comes out. Right? So that gastrocolic reflex, that increase of peristalsis after you eat something. So use that to the advantage. Time it around that. It is a process, a very long process. If you're gonna watch anything, and I'm hoping we have time, watch the video on the last, I think it's the last slide, I have to look, there's videos, the bowel regime, bowel training, we look up the title of it. Quad morning routine. Quad morning routine. It's on like slide 41. Life after injury. It's an 8-minute video. Shows you spasms, his posture, his bowel regime, the process it takes when you get up in the morning to be ready for the day. Don't ever take for granted hopping up out of bed, I'm late for school, grabbing a coffee, get in the car, and off you go. That does not happen for somebody who has a spinal cord injury. It's a much lengthy process for someone. So using that gastrocolic reflex, thinking about the foods that you eat, right? Hydration, knowing that some things cause us to be constipated. Caffeine takes fluid out of the stool, so be mindful of that. You can't just only drink coffee. Can you have coffee? Yes. Should it be an exorbitant amount all day long? No.
Have it after.
Or before, right? Because a lot of times it'll stimulate the bowel movement. Some kind of stool softener, some kind of either ditch stim, where you take a finger, I always double glove if you're doing ditch stim, right? Because you wouldn't want your glove to break, so double glove. What did you say? Here we go, here comes Ryan.
Everybody gets it.
Everybody, no, everybody just not get ditch stim. Insert your finger, not the first thing in the door.
While you're at it, you might as well suction them.
So, seriously though, circular motion with your finger stimulates peristalsis of bowel movement. Some patients just need that, and now you're not using enemas, you're not using laxatives. Laxatives can become very dependent. We don't have to use them. We do not want to use them. Because then you can become tolerant to it, and it's only going to get worse the longer that you have this condition. And it's a lifelong condition, right? So many times you use glycerin suppositories. Who's at Gaylord? What are you guys using?
Just Miralax.
Miralax. Okay? Once a day. And in report, is it a guarantee that they're talking about how the patient moved their bowels? Yes, absolutely. Does the patient need to monitor how you're moving your bowels? Yes. They either need the mirror to look or look, in the toilet. Maybe they have a shower chair over the toilet. They should be looking at it, or someone else looking at it. Small amount, moderate, large. Because if it's a small amount, are they going to have to go get later? Are they going to be able to feel that? No. Now maybe they're down in physical therapy and they were incontinent. What does that do to you? right? Very embarrassing. Okay? It's not like he can just get up and move, walk away. He can't. Right? So wobbles is a huge thing for someone who has a spinal cord injury. Is it hard, soft, loose? Always go back to that assessment. If the patient's having a problem, okay, let's go, start back at the beginning. What's going on with the wobbles? What do they look like? How much? Assess that first, and then go forward. Okay? They could have a GI bug, who knows? Is that what you said?
I'm saying like maybe it's with that.
Oh, group diary. Okay. So your goal is to always assess them and prevent incontinence. Prevent incontinence. So now he's going to go home. He's been in rehab for a while, and he's going to go home. So what are our long-term effects and considerations when he goes home? Where is home? First of all, can he go home? Can he go home?
We don't know.
Well, we better know, because we're sending him out the door. Where are we going to send him to? Somewhere where he's going to get assistance, help that comes in, or he can physically do it. And what else? Somewhere that's safe. Are the tools, the ability to get into the home, out of the home? Maybe there's a couple of steps, do you need a ramp? Is there a bathroom on the first floor? Do you have a shower chair? Do you have the wheelchair yet? Do you have all the things that you need? There's lots of. Do you have all your supplies? They may send you home for a weekend and then come back. What were your challenges? Okay, let's work on that. Right? So it may be incremental in nature too. Neuro, what's going on neuro? Back to this big sheet here. So autonomic dysreflexia is a possibility. Not everybody gets it. You have to be T what? 6 or higher. Injury. Spasms. So the patient is probably going to, well certainly this patient is going to have spasms. Is that a good thing? Or spasms? What do they look like? That's stiffening. So it does promote some blood flow, it promotes muscle contraction, so there are some benefits to it. But sometimes they can be so debilitating that it can flip the wheelchair over. Sometimes it's a great warning sign if someone has an infection or they're getting sick. All of a sudden, geez, I'm having more spasms, or my spasms are worse today. What's going on? There's something stimulating this a little bit more. I shouldn't be having this many. Okay, so patient may have spasms. We look at those as a warning sign as well. What about respiratory? Pneumonia. So you want a pneumonia vaccine, flu vaccine. What else? You want them to take some good deep breaths. You want them moving around, turning and positioning, getting up out of bed, not laying in bed all the time. What do you do about that? So assist cough. Maybe they have a machine for that at home. See, maybe you can get a machine. Absolutely. What level injury are they, right? Do they need to be on the mat all the time or not? Again, depends on your level of injury. Monitoring for that weak, that cough, monitoring for attempt. No different than all of you when you get sick. But they can't cough as well. So high risk for pneumonia for them. Cardiovascular, yeah, so hopefully if you know autonomic dysreflexia, whether you put it in cardiovascular or neuro, totally up to you. But we're concerned about that high blood pressure. Again, very short-lived event, hopefully, that we can find that stimulus. If not, then we need medications. What else are they still at risk for? DVTs and PEs, thrombosis. So what do they need? The TEDs, range of motion. So we're gonna need somebody else to do that range of motion for them. Okay, that range of motion also helps with contractures, with spasms, decreases the spasms. Range of motion is a beautiful thing. Maybe they're on an anticoagulant, maybe they're not. Maybe they have a filter in place, IVC filter, an inferior vena cava filter. That would have happened in the acute care setting when they placed that. What about GI? Bowel regime forever. Diet, hydration. Range of motion's gonna help with that. Good nutrition will help with both the bowel and the skin. GU. Yeah, about bladder draining. So what's their regime? Straight path. Who's gonna do it at night? Are they doing it? Is somebody else doing it? Are they able to go every maybe 4 hours throughout the day, maybe 6 hours at night? Maybe they can work up to 8 hours at night, so you can sleep well. Instead of putting the lights on and not opening the tab, right? Monitoring that output, the amount, the color, clarity, incontinence, avoiding that autonomic dysreflexia. Skin?
Breakdown.
Always concerned about breakdown, always. Diet, hydration, firm position, wheelchair lifts, skin checks, owning promises, moisturizers. Being careful of the heat and cold now. And sometimes, because are you going to feel it? No, maybe not. So being mindful of the lack of sensation. Mobility, again, what are they using for their mobility? Braces, wheelchairs. Does it have an effect on the skin? What about neurogenic pain? What does it feel like? Right? And with the neuropathy, pins, needles. Assessing the quality of that. Administering medications for that, being on those medications for that. Psychosocial, do we have altered family dynamics now? Oh my gosh, their life is not the same. Doesn't mean they can't have a productive life. It means it's not the same. How they cope with it is going to have a big impact of how were their coping skills before and the ability to adjust to now. Some patients that are high level quads, C5, they will end of life measures, meaning have a living will and DNR order in case something occurs, pneumonia, infection. They do not want to be resuscitated because their quality of life. Or maybe they want to be discontinued from life support. So a lot of psychosocial, economic loss. Are they going to be able to keep their job? Where they were? Who's going to love them? Are they still, you know, in our society, it's very much about how you look, what you can do, how you provide, right? Perfect little house, picket fence, good old American way. So what does that mean to someone who now can no longer provide? Right? Right, a lot of anxiety, depression. Absolutely. A lot of strain on the family, because maybe they need help with their personal care. And who's going to do that? Do they have insurance to cover that? Where they can get outside help? Sexuality, pregnancy, lots of issues, right? A lot of concerns. Or complications, the depression, skin breakdown, infection. All right. I'll let you fill in the rehab column because that's kind of a blending of both. Let's take a look at that video. Let's see, that would be the start.
Hey, it's me, your skin. Help me maintain my moisture balance while treating acne with CeraVe Acne Foaming Cream Cleanser.
I'm glad to see the proposals have been presented today. I'd like my colleagues to understand.
Hey guys, so today I'm going to be doing a voiceover for my bowel program.
See the spasms? Yeah. Okay, so this young man lives at home. This is his mother. You can see the straps in bed. You can see the Foley catheter, or it's not Foley catheter, I believe it's a condom cap for at night. But look at the hand, how the hands are placed, what he can do, what he needs for assistance. Watch it like a nurse. You're a nurse.
Team. This is something I do mine every other day, and it's something that every spinal cord injury person has to do with. It's basically going to the bathroom. So for me, I don't know if you saw me kind of sit up in the beginning. Usually every morning when I wake up, my body is super spastic. I'm able to actually sit up, and then my mom will undo the tie downs and my legs will kick up, and I'll roll to the side and have them put in the suppository. I usually wait about 10 minutes, and then I'll roll back over and they'll pull me to the edge of the bed, which is what they just did. And then I usually need help getting onto my commode chair, so I have 2 people, my mom and dad, help. We call it a 2-man lift onto the commode chair, and then they put my feet on, kind of get me adjusted, pull me up, make sure I'm all straight, and then once I'm all situated, they will roll me into the bathroom. So after I get rolled into the bathroom and over the toilet seat, I'll usually have my mom give me my toothbrush, and then I'll brush my teeth first thing in the morning. I just like to do that every morning, get that morning breath away. And then after I brush my teeth, I'll have her come in and give me a water bottle to drink. I try to drink a full water bottle every morning, not just on my bowel program days, but just to kind of help get my insides moving and waking up. And I found when I do my bowel program and drink a whole water bottle, it helps me go a lot better and everything goes more smoothly. So after I do that, I usually just go on my phone the whole time while I'm going to the bathroom. It usually takes anywhere from 30 to 45 minutes.
30 to 45 minutes.
after I'm done going, my mom will roll me into the shower, and then she'll turn the water on and kind of just spray it over my hands to kind of get my body used to the water. If she just starts showering me right away, my body will spasm and my legs will kick out. So my body just kind of gets used to it, and then she'll just get my body wet, and then she'll scrub me with the scrubber and soap. And then after that,
Now you need a shower that you can, wheel the chair right in. Not everybody has that, right?
Or the chair to fit in the bathroom, period.
Correct.
That would fit my
Correct.
usually will clean my face with this face scrubber, just to kind of get all the oil and grease off my face, just to clean it. I noticed if I go a couple days without cleaning my face, I'll end up getting some pimples. So that is why I try to clean my face as much as I can. And after I do that, she'll wash my hair. Today I just used water and didn't use shampoo. And then after I'm done, she'll dry my head off and dry off my body, and then roll me back into my room to transfer me back onto my
Good
bed.
attitude, right? Yeah.
We'll give you my notes.
So once I'm back in my room, my mom will bring in my other manual chair, and she'll put my feet up on it. And this is the way that we do a single transfer from the commode chair back to my bed. And it just kind of helps take a little bit of the weight off my body by resting.
So now, at Taylor, have you guys been seeing slide boards?
Yeah.
So you can use a slide board. Does everybody know what a slide board is? It's a board that you would put from the chair to the bed, right? And you would just slide the patient on it.
I use the Hoyer usually.
Or you can do a Hoyer. What's that?
You can use a sliding board with one person who has no leg.
Yes, yes, absolutely. Yep. You would stand in front of the patient. And the patient would put, he could do it where this chair would be back further. The chair is higher than, needs to be higher than the bed. It's very difficult to go up. You want to slide down, right? And his arms would go around you, and you would just slide them. Okay?
Feet on the manual chair, and then shoulders come from behind me, and we'll count to 3, and then we just go for it. And she pulls me onto my bed, and this is the method that we found that works best for us. I'm about 6 feet tall, and she's about 5'4", so I'm really heavy to lift. After she gets me on my bed, I'll roll over and then kind of dry off my back and my butt, and then she'll roll me back over. And then after I shower, I have her put lotion on my legs, because I've noticed my skin gets really dry after I shower. And then since I drink a whole water bottle before showering, I usually have to pee by the time I get back on my bed, so I just have a pee cup that I can just pee into. I'm able to do that on my own. So that was the red cup that she took away from me. And then after I'm finished with that, we'll put on my shorts, or today I put on sweatpants. And then after I have my sweatpants on, she'll put my shoes on for me. Once my shoes are on, and we will do a single transfer back to the bed, so my mom will pull me to the edge of the bed and then sit me up. And then once I am at the edge, we'll kind of do a 1, 2, 3, and then she'll transfer me over into my chair. And then once I make it into my chair, I'm usually slouching, so she'll come around and pull me up straight. And then once I'm up straight and secure in my chair, I'll have her adjust my shorts and de-wedgie them and just kind of straighten them out, because they're usually all bunched up. And then once I'm secure in my chair, I'll have her put on deodorant for me. And then after I have deodorant on, I'll have her put lotion just on like my arms and shoulders, because again, my skin gets really dry after showers. And then once I have my deodorant and lotion on, I'll pick out a shirt and have her help me put her shirt on. After that step, and there are a lot of steps in getting me up and dressed, I will have my mom help me do my hair. I don't have use of my fingers, so that's not something I'm able to do on my own.
But he could
And
have an
then after
adapter
she
where
kind of
he
does my
follows
hair,
the brush
I'll
in,
put
does
some
himself, right?
face lotion on my face because my face gets really dry as well. So I can put that on myself, and then she'll put some wax in her hands and help me do my hair and get me looking good. So after all of that, I will then put on my common calf and leg bag, and that's what I wear. So that was just a picture of my common calf and the leg bag I use. Since I'm wearing sweatpants today, I kind of have to feed the tube up through my leg, and then my mom will attach the bag to my leg, and then put the common calf on, but I didn't show that part. And then, so this device is called a JB3 system, and it allows me to drain my bag all on my own. That lever that I'm holding right now, when I pull that, it will, right there. So this is what the system looks like, and when I pull the lever, that black tube and that device that's attached to it will release, and I'm able to drain the pee out of my bag, and then when I let go of it, it pinches the tube so the pee can't come out. It basically gives me most of my independence. And then I'll put on a black Velcro strap in front of my legs so my legs can't kick out throughout the day because I have pretty crazy body spasms. And then once I'm done, put on a jacket and then give my mom a hug because I don't give her enough of those and she really is amazing. So thank you, Mom. And then after this, I'm pretty much all dressed and ready. I'll get on my motor, which is called a ZX1.
So look, he can move around, right, with his hands on a manual chair. I suspect he's a cervical injury, probably a 6, C6, 5, 6, 7 area, because he does have that dexterity in his arms. He can move his arms around. He can manually move a wheelchair. He's going to get really tired, yes. So if he needs to go distances, what a great thing this is that he can now be electric. Okay?
Wouldn't he not be considered quadriplegic? I see on the video it's called quadriplegic.
Right, because he does have impairment in all 4 limbs. So did you notice his hands, how his hands are contracted and how he doesn't have that fine motor dexterity? Abdominal muscles are kind of non-existent, right? He slouches over like this. He can't sit himself up. I'm sure he can't take a very big, deep breath, cough. If he gets sick, he's going to need that quad coughing assistance.
And it just attaches to my manual chair. So at this point, I'm pretty much all dressed for the day. My friend came over to pick me up, and I'm going out with him. So this is my car that I get driven around in. It's a van, and it has a ramp, and I just roll into the passenger side, and I have these tie downs that clamp onto the back of my chair and tighten down. I don't drive, as you can see, so whenever I go out or my friends pick me up, they just put me in the passenger side, tie me down, and then take off. So thank you guys for watching this video and let me know.
So someone who's very debilitated still has a lot of independence, right? A lot of support from the family.
That probably took him years to do though.
Yeah. Who knows? Could have money from a lawsuit based on the injury that occurred. We don't know any of that, right? There is another video, home modification. That's every bell, every whistle. I don't know how that person got all that. Again, maybe they had the finances, or maybe there was a lawsuit and that's how they acquired that. Not very realistic, all those home modifications.
So that lever that he has to release the urine, does he have to be like outside in the grass or something to do this? You know what I'm saying?
Where are you gonna urinate?
I mean, but it drops down under him, it looks like, and so I'm asking.
What do you mean? You're outside, right?
Oh,
You
okay.
don't want to be outside.
All right. I didn't know how it works.
So if you have a lever that you're gonna pull to open your leg bag, unless you have somebody who's gonna put a cup or something
Right.
else underneath, you should be outside.
Okay. Just asking.
Think about where you're at. You could be in a handicapped bathroom that has a drain in the floor. Could be right over the drain. Pull your lever, he can do it by himself. Right? So his biggest challenge would be if he was incontinent throughout the day. Otherwise, he's good to go. Right? Or any kind of devices that he would be able to use a spoon, fork, knife. Right? So they could put a sponge around the handle, so that way there it can slide. Somebody could slide the device here, and now when I've got the movement, right? You saw him rub his face. He just can't use his fingers, but he's got that dexterity to do this. Good, but helpful to see that, because if you haven't taken care of somebody with a spinal cord injury, it's difficult to grasp the spasms, the care that is needed for this patient. Questions? No? All right. How about I go through just an overview to make sure that we hit everything regarding, I'm not going to talk about each slide, but just to kind of wrap it up and summarize things, right? And then if you have questions as I'm going along, write it down, so that way there we can go back and talk about that. Because I want you to leave today with a really good understanding of spinal cord injury. It's a lot of content that is going to be on the exam next week. All right? So spinal cord injury, we know that there's many systems involved. All right? The cause can be numerous. It could be something that's a traumatic event, or something that could be as simple, but something that is a disease process that is exacerbated, like metastatic cancer. Okay? We're focusing on that acute traumatic injury. It's most common in men, most common for motor vehicle accidents. For the elderly, it's falls. So I think about prevention, and I think about fall prevention. About seat belts and speeding and texting and drinking and driving, right, as prevention. Oops. So some kind of event happens where there's a primary injury, whether it's flexion, extension, joint rotation, right, to that spinal cord. Immediately or soon thereafter, hypoxia, inflammation, edema occurs in that area, and it can cause secondary injury, which means we don't know where the true injury is. The patient can appear worse than their true actual injury. And it takes time for that injury inflammation to subside, that edema. It's classified as paraplegic, 2 limbs, quadriplegic, 4 limbs, or tetraplegia, 4 limbs. It can be complete where you have no motor or sensation below the injury, or incomplete where you're getting some messages that go back and forth. Your best outcome is those incomplete injuries. We see recovery up to about 18 months. So it takes a long time. It's slow, it's steady, it's a snail's pace, but it's okay as long as you continue to show improvement, there still continues to be hope. And it affects every system. You may have paralysis, loss of movement in any part of the body, and again, on different types of injuries, you may have loss of movement in your upper extremities, but you can walk. we didn't even get into the weeds of all that. We can see any configuration of that. But what we do know is that if your lumbar sacral area above, it is going to affect your bowel and bladder. So pretty much every patient, for the most part, is going to have some kind of issue with a neurogenic bowel and bladder. And we ultimately will have regimes for that. You may have some neurogenic pain. We didn't even go into. I'm going to let you watch the video on, or the 13-minute PowerPoint on neurogenic pain. And we're most concerned with those ABCs, right? Airway, breathing, circulation. It's so important to make sure that that spine is immobilized. So when you come upon a patient that fell, you have to be worried about spinal cord concern or a trauma. You can mobilize that patient without a cervical collar. You can do a manual hold. If you need to do CPR, you can do the jaw thrust. No head tilt, chin lift. We're doing the jaw thrust. Okay? So immobilization is very important. Patient will have some diagnostics, obviously. We need some kind of CAT scan to see what's happening. We want to check the CBC because what if they have other injuries? Bleeding. I'm most concerned about bleeding that I can't see. So I'm looking at that H&H. I know that they're probably going to be in neurogenic shock, right? So I expect the blood pressure to be low. I expect the heart rate to be low. I'm going to give some fluids. Be mindful of too much fluid because they could go into fluid overload very easily because they have enough fluid. My capillary membrane is okay. I'm just vasodilated. So I'm probably going to need some pressors too, but I still start with my fluids. My heart rate is low. We can give some atropine. If it's less than 40 in the 30s, then they're probably going to need some kind of temporary pacemaker. All right, whether it's external pads until a temporary wire gets inserted. Respirations, right? Or airway. Do they have a pain in the airway? Are they able to breathe on their own? Do they have enough respiratory effort? Or do they need to be intubated right away? If they're a lower level injury and they're breathing on their own, well then we're not gonna advocate for them to be on the ventilator because that comes with its own set of potential complications. But boy, I better monitor that patient closely because if that secondary injury, that edema, causes a higher level presentation on the patient over the next 24, 48, 72 hours where that edema peaks out, that swelling, then that's when my patient's most at risk for that further respiratory compromise. So making sure that they're stable. I know level C1, 2, 3, absolute guarantee vent. Hopefully they survive at the scene. C4 does your diaphragm. So that person's going to be on a ventilator as well. 5, 6, and 7, prophylactic on the ventilator. Because we anticipate that they're going to need it through this short time frame. Thoracic injuries, well, that T1 through 5 is going to be your thoracic intercostal muscles. You should be okay. Your lower thoracic is going to be abdominal muscles. I'm okay with that for right now. Okay? Let's see. I know that initially I'm monitoring them. I'm focusing on my neurogenic shock. We talked about the blood pressure and the heart rate, what our goals are. That it's significant for someone who's T6 or above, knowing that when you start at the base of the skull, it goes 1, 2, 3, 4, 5, 6, 7, and then it starts thoracic, 1, 2, 3, 4, 5, 6, right, all the way down to 12. in that order. So be mindful of when someone says T6 and above for injury, and the effect of that injury is on T6 and below, right? Don't mix up that terminology of where the injury is and the effects on the body is below it, okay? Hypothermia, we know the skin body temperature is warm. However, we know their core temperature is cooler, so warming blankets. Prone to clotting with all this venous cooling. So any kind of DVT, PE prophylaxis. Here's my vasoconstrictors. Norepinephrine is typically the drug of choice. My patient's in ICU, if not in the ED, then the ICU at this point, hopefully a neuro ICU. I'm monitoring that IV site. Hopefully they've got a CVAD because we don't want this to extravasate, go into the tissues, right? Then that's a whole nother set of problems. Cardiac monitor as well. My goal is that they're going to have their blood pressure come up and their fluid balance is going to level out. They're going to have some urine output. We started talking about this a little bit as far as the different levels that you need to know. T6 is a huge level, right? This is where T6 and above, any injury above that, neurogenic shock, autonomic dysreflexia, high risk for orthostatic hypotension. So what does that mean? I want to move my patient as soon as possible. So once I have them stable, turn in position. It promotes that good skin care too. So turning side to side, head of the bed elevated, down, up, even up out of bed. Spinal shock, we talked quite a bit about. I'm hoping that you're feeling okay with that. We know that when someone's in spinal shock, they're also going to have hypomotility, and certainly a T5 or higher hypomotility. So they need an NG tube to suction. But I'm going to want some nutrition because that spinal cord wants good perfusion, oxygenation, and nutrients while there. So hopefully within 24 or 48 hours or so, we're thinking of some kind of nutritional, whether it's a TPN or whether it's a EAT or enteral feeding. Again, it's going to depend on the motility of those bowel sounds. Initially, the bladder's atonic, they need a Foley catheter. Later on, that'll come out, and we go to intermittent caths. We talked about skin breakdown, the importance and all the interventions regarding skin. They need some kind of stabilization of that spine, of that vertebrae. If they don't need surgical intervention, maybe they just need a device like the halo that is going to restrict their movement to promote stabilization. Or maybe they need to go to the OR to have rods placed in and fragments removed. If that's the case, now I'm taking all those post-op care and I need to bring that in, right? Post-op care. When I think about post-op care, I think about wind, water, wound for infection, right? It's going to happen in my lungs first, wind, water, my urinary system, and then my wound, wherever my incision is last, days later. I want to make sure that their oxygenation is okay, their blood pressure is good, hemodynamically stable. Are they making urine? What's the labs the next day? Right? Post-op care. Worried about embolisms. They need sequential compression device, right? SCDs on. If I have a halo, it's rods that are screwed into my scalp. So I need to do pin care. I need to look at that insertion point. Okay, is there any drainage? Is it red? Never ever grab those bars. The bars are attached to the halo. They do have a vest. It stays on for months. That hard vest stays on as well. It does have Velcro on the sides, so that fleece underneath I could take off and wash it, throw it into the washer. I'd have a second set that I could slide underneath and put on. Patient can still wear clothes. You would just probably need Velcro on the sides or in the front so you can slide it on. You want to make sure that there's nothing, the skin underneath the vest is okay. Wear it for months. Think about, this is the person, they might be able to walk. If they're walking with this, it's heavy. So their sense of gravity, especially at first, is going to be off. I'm concerned about fall precautions with this patient. All right, as they get used to it, may not be so much of a deal, right? But if I get them up into the chair, this thing is so heavy as they lean forward a little bit, they might come right down, right? Fall out of the chair, that'd be bad. So be mindful of the center of gravity and how it changes for the patient. In our video, we saw he almost fell a couple of times. Very scary, right? We could really critique that video of what we could change, but we're not going there. Okay. We talked about most of these things. Orthostatic hypotension, as far as what we can do with that. Here's a picture of a gentleman that was on a tilt table. So this is in the rehab phase that you use a tilt table. The patient lays on the table, and again, for severe orthostatic hypotension, maybe they can only go 45 degrees or 90 degrees before they can go all the way to the upright position. We know that autonomic dysreflexia is an emergency. You must know autonomic dysreflexia. I would not be surprised if on your NCLEX, if there's a question about spinal cord injury, it is about this. Must know this. It only occurs after spinal shock has subsided or begins to subside. It's simulation of that sympathetic nervous system. What do we see? We see hypertension, we see bradycardia, they're flushed, anxious. Again, each person's a little different. It's T6, wow, that number just keeps coming back. T6 or higher. All right, what are we gonna do first? We're gonna check, we're gonna sit the patient up to promote venous cooling, and then we're gonna check the bladder. That's if we already know the vital signs, right? But if a spinal cord injured patient with a T6 or higher level injury calls you and says, I've got a headache, you better be checking the vitals right away. Because maybe they never had it before. They're not even realizing the other parts of that. Once they have it once, they're able to direct their care. All right? In extreme cases, they may need medications, a vasodilator. We're concerned about this elevated blood pressure. We want to get it down. If we remove the stimulus, it'll come down like that. As soon as the patient can, they need to go to rehab. Your best outcome is get them to rehab. How much rehab you do in acute care? Hardly any. In acute care, hardly any in acute care. They need to go to rehab. Rehab is the goal, the focus, for them to be independent, to care for themselves, to learn how to care for themselves. There's a whole team. The nurse is at the center of that team. They're reinforcing what's going on in PT, what's going on with occupational therapy, what's happening with wound therapy. And that's part of your treatment plan, is to utilize all the recommendations from all of these other disciplines. We know the patient's got a neurogenic bladder. Intermittent cath is your best means for a bladder routine. We want certain parameters. It's typically every 4 to 6 hours where we're going to look at that urine output, around 400 or 500 max. Otherwise, we might need to do it more frequently. What's the amount? What's the color? What's the clarity? Is there any odor? They're going to be having medications for this bladder that's spastic. We don't want any incontinence. We want that bladder to be able to distend a little bit. So meds for overactive bladder, nifedipine, oxybutynin. Baclofen, look at those spasms that the boy had. That'll help suppress, muscle relaxant, suppress that activity, spasms, incontinence. Neurogenic bowel. What was their routine before? We probably want to mimic the same routine. If they went every day, well then we're going to get you going every day. When you're in the rehab setting, because you're doing physical therapy all day long, many times your bowel regime is at night. Because does it not take a long time? Holy cow, you'd have to start at the night shift, probably 5 a.m. We're not going to do that. We want to promote rest and healing and sleep. So when you're in rehab, the bowel regime tends to be at night. When you go home, most people do it in the morning. They'll switch it to where it's in the morning. Why? Because you don't want to be incontinent. So if you can empty out those bowels effectively, a good bowel movement, less likely to be incontinent. Yes, good nutrition, hydration, stool softeners, hopefully not laxatives. Hopefully you're using something like Digstim or glycerin suppositories or a Miralax, something that's not dependent. Limit your laxatives. You have to go start slow with it. Otherwise, you're going to end up incontinent. Limit your caffeine. Otherwise, you may have difficult time going, right? Because it pulls that fluid out of the stool. Use that gastrocolic reflex. Sitting up as much normalcy as possible helps to get that body reacclimated. Right? Best outcomes. Our skin, holy cow, we can't move and we can't feel potentially, or it's altered. So skin integrity is a very big focus for patients with spinal cord injuries. Think about all the good skin care, nutrition, hydration, moisturizers, skin checks, inspections, mirrors, taking a picture with your cell phone so I can see it, so I can analyze it. Because I, me, the patient, need to direct my care. All right? Thinking about devices, braces, splints, wheelchairs, anything, the straps across his legs. If he has shorts on and the strap is across his legs, is it too tight? Is it going to dig into him? Now maybe he has a lot of spasms if it keeps rubbing. Maybe it would alert him, but maybe it wouldn't either. So again, looking at the skin, what does it look like? Taking care of it before becomes a big problem. Health promotion, alcohol. We all get a little sloppy when we drink alcohol, right? So are you going to be maybe not straight caffeinating yourself or having somebody do that? If you're drinking too much, you're taking fluid intake more. Especially if you're drinking beer, I'm thinking, right? How about, are you repositioning yourself? Are you making good choices? The skin temperatures and, again, braces, devices, clothing, shoes, concerned about the pressure that's on the skin causing injury. And obviously the temperature. Spasms. Spasms are a good thing and a bad thing all at the same time. Good thing in the sense that it does promote circulation and blood flow. It can be a warning sign. So if I have an infection and my spasms are worse, then I need to say, oh, something's going on. This is out of the norm. I better look a little deeper. They can be bad in the sense that it's debilitating. If he has a spasm when he was getting out of bed with his mother, he almost fell. If he had a spasm right then, he's going down, right? We don't want to cause further injury. We don't want anybody to fall. If you're strapped into a wheelchair and maybe he didn't have the strap on the lower extremities good enough or forgot, whatever the case may be, then all of a sudden now has a massive spasm, legs up, he can easily flip over. Okay? I've seen it. Not pretty. Psychosocial, coping. Are they going to be in shock? Yes. Maybe denial. Are they ever going to accept this? Probably not. They have to learn to cope and adjust with it. This is life altering. Every aspect of your life is different, and you are dependent on someone else for everyday function. Right? So don't ever park in the handicap spot if you're not. I have some friends that have spinal cord injuries that occurred throughout our lives. And it cringes me when somebody jumps out of the car because a person with a spinal cord injury that can maneuver their wheelchair alone and wants to be independent and wants to be normal. What's normal, right? It's different for each person. Yet someone will jump out of their car parked in a handicap spot. Sorry, it's a pet peeve. Let me get back to it. Okay, so long-term complications. Sorry about that. The skin breakdown, the spasms, always risk for infection, whether it's pneumonia, wounds, right? Autonomic dysreflexia, depression, disuse syndrome. How about heterotrophic ossification? That's that lack of movement and overgrowth of bone when you're not using it. So range of motion is so important. If your spasms were like he was, the gentleman in the video, they should be doing range of motion before you even get up out of bed. Right? Because then that transfer getting to bed is going to be that much easier. Less chance of that stimulus causing a spasm. Where is home going to be? Do they have the ability to go home? Do they need to go to a skilled facility? How do you think his demeanor would be if he was in a skilled facility? Maybe an apartment complex, senior housing. If it was more situated where the doors are bigger, it could have a handle instead of a doorknob. He can't open a doorknob. A doorknob like this, and maybe there's a string or a bar, so that way there they can hook on it. Of course, it's locked, so I can't show you. Right, but they can push on it with their side of their hand, and then maybe hook on with their hand. I don't need my fingers to pull the door open. Little things, right? The rug, trying to get over the rug. Oh my gosh. All right. Adaptive devices so they can eat, care for themselves. Reachers. Lots of research that's going on. Still a long way to go. They're using a lot more exoskeletons now, which is this device on the outside. So that way they're a little bit more robotic. But it gets you upright. When you're sitting all the time, it's nice just to stand. There's wheelchairs that go to the standing position. It's good to bear weight on your feet. Right? If you can tolerate it. You should be able to, that's part of your plan, that get over that orthostatic hypotension. So we can have you stand up if possible. Don't you think you'd feel a lot better if you had a wheelchair and you're at a gathering? Do you want to be the only one who's sitting and everybody's hovered over you? Instead of you, even though you have a device, you're standing amongst the group. Question? questions? Helpful?
Yes.
Okay. I could read off the Neurogenic Shock. I don't think I need to. I think you can do that on your own. Those two medications, anticonvulsants and, tricyclics. Do you have a question or a comment?
I do.
No, that's a good thing.
Dyslexia again.
Okay.
It's always from a spinal cord injury. So you have to have spinal shock first.
No, you do not. Two separate things. The only way they're connected is that you cannot have autonomic dysreflexia when you have spinal shock. Why? Because autonomic dysreflexia, yeah, there's a stimulus. When we have spinal shock, there's nothing. We got nothing. Okay? And again, if we get into the weeds of spinal shock as it starts to come back, it's this reflex. We're not going there. We're not going that deep. We don't need to.